Chairman Sanders, Senator Warren, Senator Baldwin, and other members of the committee, thank you for this invitation to testify. You've chosen a very provocative title for this hearing. It calls for a straightforward response that outlines more than the situation, but also includes potential solutions. So first, I'm going to describe very briefly trends in life expectancy and the unequal distribution of risk of death by socioeconomic status in the United States. Then I'll go to some practical options for improving the nation's health. I'll focus on work policy, particularly here, because it's an area in which the federal and state governments have a role in shaping policies that would reduce health disparities. First, as we've said now, U.S. life expectancy has lost ground compared to other nations in the last decades, especially for women. I was a member of a National Academy of Sciences panel on longevity trends. It found that the U.S. ranked at the bottom of 21 industrialized, developed nations. These low rankings are particularly striking for the poor and for women. Of utmost concern is the widening gap in the risk of death between those at the bottom and those at the top. This gap has widened over the past 25 years. So, for instance, in 2007, the death rate for men without a high school education was 7 per 100. It was 2 per 100 for those with a college education. So this corresponds to a 3.5-fold increased risk for those less educated men. This risk has grown substantially over the last 25 years. Among women, the patterns are even more troubling. For less educated women, the risk of dying actually increased, as you noted, in absolute terms during this time. Most striking, this pattern holds even if we only look at white women in the United States. Now, using a public health framework, I want to show how labor policies and practices can make a difference in Americans' health. Although health insurance and access to medical care help reduce risks of financial catastrophe and also help cure disease once it occurs, health care alone cannot prevent disease. It's like aspirin and headaches. Aspirin can cure a headache, but headaches are not caused by lack of aspirin. They are not aspirin deficiency diseases. So to reduce headaches, we need to focus on the causes of headaches. For the same reason, we need to look at what causes these high rates of dying among the poor and less educated. So turning to work then, a number of studies on the relationship between work and health show that employment is almost always associated with better health. These associations last well into old age and relate to reduced mortality risk as well as to the maintenance of cognitive and physical functioning. Here are 3 specific work-related policies that promise to improve health, especially for low-wage earners and their families. First, the Earned Income Tax Credit Program. EITC is associated with improvements in infant health and decreases in smoking among mothers. Getting the EITC means that your baby, on average, will be 16 grams heavier. To put that in context, it's equal to about 1/3 of the association between birth weight and having a mother with a high school degree. EITC reduces the odds of maternal smoking by 5% and increases mothers' odds of working and increases her wages. 2, recent evidence on maternity leave policies in the United States and Europe suggests that protecting employment among expectant and recent mothers leads to better long-term labor market outcomes, including wage level and growth, career prospects, labor market attachment, and employability. Mounting evidence suggests maternity leave is health-promoting for infants and for their mothers throughout their lives. 3, work-family practices. In a study we did of employees in long-term care facilities, which is primarily a low-wage working group in a very highly regulated industry, we found that when managers were attentive to work-family issues, their employees were half as likely to have cardiovascular risk compared to workers who had less family-friendly bosses. Specifically, these employees were less likely to be overweight, they had lower blood pressure, lower diabetes. The health effects that I've described here are not counted in the current cost-benefit metrics of these policies. So we dramatically underestimate the real benefits that they have. Our labor policies challenge working-class families to remain simultaneously committed to work and to family. Over half of low-wage earners lack sick leave to take care of families. I could give you more policies that would help the health of our low-income working families, but I'll stop here. The EITC, pro-family work policies and practices, parental leave are just 3 examples of policies that impact the health of low-income working families. Thank you very much.